Hello, I'm Hematologist Oncologist Dr. Tony Talebi. We're back with Dr. Jeff Weber, a senior member at the Moffitt Cancer Center in Tampa Bay and director of its comprehensive melanoma program. Now we're going to discuss the management of stage 4 metastatic melanoma. Thank you for being here.
My pleasure.
Right, Dr. Weber, assuming a patient has come to you, they've been diagnosed with melanoma, and the CAT scans show that the cancer has spread outside the original mole. What happens next for that patient?
Well, first, I would certainly get a biopsy-proven diagnosis of metastatic disease. As you may remember, the first rule of oncology is always verify that when someone appears to have metastatic disease, you do it with a biopsy. Okay. So once that's done, and it could be done with a fine needle aspirate, it doesn't have to be a big chunk of tissue, you have to get a feel for where is the disease. You need to stage the patient appropriately. MRI scan of the brain with gadolinium, a CT of at least the chest, abdomen, pelvis, and I would add the neck if there's any indication of neck disease. And then you got to stop, and you got to gauge a couple of things. One of them is, what are the goals of the patient? How aggressive do they want to be? What kind of shape are they in? Meaning, are they a 30-year-old who's an excellent athlete, who's very aggressive, who's open to any aggressive potential suggestion for treatment? Or are they an 85-year-old for whom quality of life is much more important than achieving a response? And then finally, you have to gauge the biologic aggressiveness of the disease inherently. If someone presents with an LDH of 8,000 and 5 kilos of tumor surrounding their left lung in the pleura, barely able to take a deep breath, that's a little different than someone with a couple of small lung nodules, each of about 1.5 centimeters, who have no symptoms. So you got to gauge, what does the patient want, what is the tumor doing, and how much bulk disease is there, and what are the expectations, and the pace. Once you get that gut feeling, which is, I guess, a bit of the art of medicine, then I think you can make some recommendations. And in this day and age, virtually every patient who's diagnosed with metastatic disease is going to get a BRAF test. In fact, I would venture to say that as of today, virtually every stage 3 melanoma patient will get their tumor tested for BRAF, because we will now soon have a BRAF adjuvant trial for stage 3 disease with this drug vemurafenib, recently approved by the FDA in August for metastatic disease. So not only do you get a feel for the patient's wishes, the pace and the burden of disease, but you also need to know the mutational status. If it's a mucosal melanoma or acral lentiginous, we'll also do c-KIT mutation testing for exon 9 and 11 mutations. Those patients might do very well with Gleevec or nilotinib. The patients who are BRAF mutated, and again, to some degree, it will depend on the pace of their disease and the burden of their disease. Those folks, you may want to start on either a clinical trial with a BRAF inhibitor or the newly approved BRAF inhibitor vemurafenib. Those who are BRAF wild type, generally your choices are immunologic. Either ipilimumab, which was a drug approved in March for metastatic disease, that's a CTLA4 abrogating antibody, or high-dose interleukin-2 in those who are under, say, 65, 70 years of age, and in your opinion, able to tolerate high-dose IL2. The median survival in recent trials with vemurafenib, the BRAF inhibitor just approved in August, have been excellent. In second line, it's been 15.9 months. That's very impressive. That's an excellent phase 2 median survival. We don't know the median survival in the front line. We call it the BRIM-3 randomized trial of vemurafenib versus dacarbazine, but I bet it's going to be just about as good as it was in the second line phase 2 trial. And that's pretty darn good. There's the debate ongoing in our little field amongst melanoma docs. If someone has indolent or slow, low-burden disease and they're BRAF mutated, should you treat them with an immunologic drug first and keep the vemurafenib or BRAF drug in your back pocket? Should you? That's a good question. I don't think there's a good answer. It is a debate that continues within our profession. I would say if someone's BRAF mutated today, my opinion is it's hard to withhold from them a BRAF drug, given what the patients know about the drug and what we know. Would it be unethical to withhold it if they wanted to go on ipilimumab or IL-2, two drugs known to produce truly long-term survival in melanoma? No, it's a reasonable approach. If you're BRAF wild type, which means you don't have, your tumor does not have the mutation, you're in that 50%, of course you go on to ipilimumab or IL-2. Chemotherapy can induce transient responses, but it's not going to cure anybody. PD-1 antibody is a new drug that's still experimental, which we test extensively here, and that's a drug with an impressive response rate in the realm of 30-35% and some long-term survivors. I would say it's a much more complex decision-making process than it was 10 years ago when you had almost no real drugs, except perhaps for high-dose IL-2. And in addition, you'll have other antibodies like CD40 and 4-1BB coming along. You'll have OX40 antibody. You'll have TIL, tumor-infiltrating lymphocytes, which will eventually be subjected to a test of their effectiveness in stage 4 disease. That's where you harvest cells from your tumor that you surgically remove, expand the cells to huge numbers outside the body, give lymphodepleting chemotherapy with Cytoxan and fludarabine, and then you give the cells and follow with high-dose interleukin-2. Complex, expensive, difficult to do, but has an impressive response rate in the realm of 40-50%. Many of those are long-term responders. So that is a trial that will get up and running soon, in the next year or so. That'll present yet another option for a potentially survival-prolonging treatment in melanoma that could even be curative. In the experience of our colleagues at the surgery branch of NCI, they have a significant cadre of patients alive at 5 and 10 years who've had this treatment. With vemurafenib and the other BRAF drugs, such as the one from GSK called dabrafenib, we don't have enough experience to know who's going to be alive at 5 and 10 years. But it's a little hard to withhold a drug with a 16 or so month median survival from a frontline patient with melanoma, especially if their disease is bulk disease that's growing rapidly. That's when you get a quick hit with the BRAF drug, and you can cause significant regression. The answer ultimately may be combinations. There's a BRAF MEK trial that we do, which looks very promising to bypass resistance. There is about to start a vemurafenib ipilimumab trial combining an immunologic agent with a modest response rate but long-term survival, with a drug which may not produce a lot of long-term survivors but has a very high response rate, vemurafenib. So there you may get the best of both worlds, and that may be the ultimate answer. And I think that is indeed the truth. It is certainly true that compared to when I was a young attending 10 years ago, or 20 years ago, the options for melanoma have vastly increased. The benefit to patients is certainly much more present than it ever was in the past. So we feel blessed that we have now multiple options that we can afford to say, well, should we go with ipilimumab or should we give them vemurafenib? Should we give them a BRAF inhibitor with a MEK inhibitor in combination, or should we go with vemurafenib with ipilimumab? We're in great shape. Or could you combine ipilimumab with IL-2? We'll do that. There are coming along a host of trials combining ipilimumab with other immunologic treatments, like PD-1, like IDO inhibitors. So we had one drug in the last 12 years before 2011, and in 2011 we've had 3 new drugs for melanoma. PEG interferon, which is called Silotron, ipilimumab, and now vemurafenib. That's pretty good. Makes you feel pretty good about being a melanoma doc all of a sudden.
And let's talk about this high-dose IL-2. You know, stage 4 melanoma, there's actually a chance that one can be cured. Would you please comment on that and how IL-2 fits into that?
That's a tough one. IL-2 is a very toxic drug that was originally developed as a regimen at the National Cancer Institute when I was a fellow, and I was there when it was happening. And the response rate is very modest, about 16%, and the chance of long-term survival is less than 10%, well less than 10%, probably in the range of 4 to 5%. A modest gain against a significant level of toxicity, and you always have to balance the potential benefit versus the side effects and the cost. I don't mean the monetary cost, I meant the cost in terms of side effects and suffering by the patient. You also have to think about the monetary cost. IL-2 is expensive. In fact, all these treatments are expensive. We're talking about prolonged therapy with each of them in the realm of $100,000 plus. So that's a pretty high cost to society.
Yeah.
So you need to use drugs at that cost, that monetary cost, carefully when you're clear that they will benefit the patient, and give them a chance of long-term survival, which at the end of the day is the name of the game. Will they live longer with this treatment or will they not? And so it complicates the decision-making hugely.
How many cycles would you give, and how do you know if it's working?
With Highdose IL2, it's given in the veins every 8 hours around the clock until the toxicity is such that you must stop. That makes it different than almost any other treatment ever used for cancer. As I tell patients, what you see is what you get. The toxicity comes on in real time while the patients are hospitalized, and they feel it and see it. And at some point, the physician has to be trained to know when to quit, when to back off. Because if you keep going with high-dose IL-2 beyond the point you should stop, you're going to cause irreparable harm. And then you let the patient recover. They go home in a few days, and they recover for a week, and then you come back and do it all over again. Inpatient treatment. We averaged 8 or so cycles the first admission week, then they get about a week off, then they averaged about 6 or 7 cycles of IL-2 the second time, for a total of about 14 treatments, given over a span of about 3+ weeks. And then you take 4 to 5 weeks off, and at the end of about the 8th week, you do a reevaluation with new scans to see if it worked. If there's evidence of regression, any regression that seems meaningful, I would do another 2 cycles. If there continues after that pattern to be more shrinkage, I would actually go to cycles 5 and 6. I've probably never gone beyond 6 cycles of IL-2 because the patients are pretty worn out by then.
So even if you continue to see regression after 6, you stop regardless?
Yes, I would stop. I've once delivered a 7th cycle and lived to regret it to a patient who really wanted it. Caused a lot of side effects. I've never gone beyond 6 cycles of IL-2.
How do you follow those patients thereafter?
In someone who has stage 4 disease that achieves a good partial response or a complete response, I'd see him every 8 weeks with scans for the first 6 months, and then I'd start to stretch it out to every 3 months for the next maybe 1.5 to 2 years. Then I'd go to 4 months for 1 year to 2 years, then I'd go to 6 months, and I'd gradually stretch out the follow-up. And eventually, at the end of 5 or 6 years, if they're doing well, I'll say, let's go to year-long follow-up.
I see.
And just say, that's great. Those are the people who may well be cured. They're a very small minority, but it's a significant number of patients, yet a very small total minority.
I see. Let's assume that the melanoma does progress after the IL-2, or the patient cannot receive IL-2 for whatever reason. You mentioned BRAF. Would you please explain what BRAF is, first of all?
BRAF is a mutation present in about half of melanomas. BRAF is just a gene that encodes a molecule that's important for the continued growth and the maintenance of the transformed state in melanoma. So effectively, if you mutate it, it mutates the binding site of this so-called signal transduction molecule, so that it's continuously in the on position and continuously promoting the growth of the tumor cell. And essentially the melanoma becomes addicted to its presence. So if you could block that mutated BRAF, as you might imagine, it would rapidly, irreversibly lead to the death of the cell. And that's the way it works. You can see miraculous responses, amazing responses. People who looked at death's door 3 weeks later look like a new person. The problem is, ultimately, over time, almost everybody becomes resistant or develops resistance to the BRAF drug. And the research today centers around what constitutes what causes the resistance, what are the etiologies of the resistance, which turns out to be manifold. It's not just one explanation. And how can you overcome it? And actually, we'll be doing a trial here and attempting to overcome BRAF resistance as part of a SPORE, a grant application that we put into the NCI.
So this medicine, vemurafenib, what are its side effects that patients may experience?
Vemurafenib has most unique side effects. The most common and significant side effect of vemurafenib is keratoacanthomas or early squamous cell cancers. It can also cause fatigue. The squamous cancers tend to come on within 2 to 8 weeks of starting treatment. They are often single, maybe 2 of them. Sometimes you can have multiple, but most of the time individual small little tumors that look like a little volcanic crater or a little volcano with a little white crater at the tip. And you surgically remove them and you continue treatment. It is not regarded as something that's going to make you stop treatment. If someone is responding to this drug, it's prolonging their life. You don't want to stop because they have a small squamous cancer, yay big. You cut them off and you keep going. A lot of patients get photosensitivity. That is, they get very sensitive to the light, and you just have to tell them to stay out of the sun and wear sunscreen and a hat whenever they go out, any time of the year, even today on a cloudy day. They have a lot of rashes. They develop papillomas, little like skin tag-like things. There can be joint aches and pains, and that's a big issue, often requiring the use of narcotic medicines. And they can be migratory joint pains, especially in the knees, hips, the hands, fingers. And you can see a lot of itchiness, rare nausea and diarrhea, rare vomiting. But the biggies are fevers, arthralgias, the skin toxicities I described, and the fatigue. Those are the big ones.
So you continue the medicine until the melanoma spreads to other parts of the body?
With vemurafenib, you treat until progression, and sometimes you even treat beyond progression. Let's say you had 50 tumors in your leg and some lymph nodes in your belly, and the lymph nodes and everything went away, but in the leg a new subcutaneous tumor returned, and there was nothing else anywhere else. I would surgically resect that lesion and keep going, because maybe that particular clone of tumor cells that made that subcutaneous lesion mutated somehow, causing that clone to be resistant to vemurafenib, whereas other tumors in other parts of the body never evolved resistance and would still be in check if you continue the vemurafenib. So no, we're aggressive about operating on patients who relapse on vemurafenib in 1 or 2 sites, not in many sites, but 1 or 2 sites, and continuing the treatment. And I think that's a bit of a new paradigm. That is, treatment past progression. It is certainly something we do with ipilimumab, where there's an absolutely unique kinetics of response where you can actually see progression followed by regression. So there you actually will want to continue treatment.
You mentioned ipilimumab. Would you please explain to our patients what is it and how does it work?
Ipilimumab is a human antibody. When I say human, it's made in a mouse. But it's made in a mouse with a human immune system, so that the antibody looks just like one of your own antibodies, and it has a long half-life in your bloodstream, weeks, 2 weeks or more. And that antibody blocks the brake on the immune system, which is overly turned on in most cancers, particularly in melanoma. So it blocks the brake and thus allows the immune system to proceed in an unfettered manner. Instead of being inhibited, it disinhibits it.
I see.
And it's a drug that actually was approved in March for metastatic melanoma and is an effective drug in melanoma and in even some other cancers.
What are its side effects?
Ipilimumab has a very unique and significant side effect profile, which stems from the fact that it's an immune stimulant. And as you can imagine, with an immune stimulant, the most likely side effects would be overstimulation of the immune system, and that's exactly what happens with this drug. It can have generalized side effects. You can have generalized fatigue or fevers. You can have rashes that are very itchy. You can also have generalized swelling of the lymph nodes, most unusual. And it's not the disease. If you biopsy it, you often have a negative biopsy in a melanoma patient who could be responding elsewhere to the treatment. It also has a number of side effects that are very tissue-specific, hepatitis and pancreatitis, that often you would detect only on lab tests. It can also cause colitis, inflammation of the colon with diarrhea. You can see nephritis, inflammation of the kidneys, or significant inflammatory rashes. You can also see pulmonary toxicity, and you can see hypopituitarism. That's remember, the pituitary is that gland right through there at the base of the brain, about the size of my pinky nail, and if that gets inflamed, it'll shut down. And with ipilimumab, you can induce low thyroid and low adrenal function as a result of this.
I see.
So it has many unusual side effects that are all immunologic in nature.
I see.
And it takes a significant learning curve to figure out how to manage them. But once you pass the curve, it's no different than any drug.
I see. It's not uncommon for patients to develop diarrhea with chemotherapy, but diarrhea with this particular ipilimumab is very serious.
Very serious and very different. Only about 6-7% of patients at the approved dose of 3 milligrams per kilogram of ipilimumab develop significant, meaning dose-limiting grade 3 diarrhea.
Mm-hmm.
And you can see bloody diarrhea if you don't pay attention to it. You have to jump on this. As I tell patients, we jump on this like white on rice.
Mm-hmm.
You got to be very vigilant about the diarrhea and about some of the other side effects.
I see.
But if you know how to handle it and if you jump on it early on, the patients are fine. This is a safe drug to deliver.
I see.
I've had maybe one death in 450 patients treated with this drug.
And do you give a set cycle, or do you continue beyond progression?
With this drug, the FDA-approved regimen is only 4 doses given every 3 weeks apart. So you give your 4 doses and you stop.
Can you use it later on, a year, 2 years later?
If, at week 24, the patients who have had an initial response then progress, yes, you can reinduce them with 4 more doses again every 3 weeks, 4 times.
So about 6 months is your cutoff?
Absolutely
I
correct.
see. How do you deal with depression and stage 4 cancer, generally speaking?
We have a very good care team with a good psychiatrist. It's a tough scenario because it's situational depression that's appropriate. I mean, who wouldn't be depressed if they had a death sentence hanging on their head and had cancer? We have a very good support team. We have very good nursing staff. And we have a very good psychiatrist and a couple of psychologists who are willing to help us. But in any cancer practice setting, I think that team is essential.
I see. How do you deal with loss of appetite in stage 4 patients?
Megace is one of the few drugs that seems to work.
Mm-hmm.
Dronabinol is a tough one, especially older folks don't take well to it.
Mm-hmm.
Often we'll put them on Ensure
Mm-hmm.
just to get those calories up because it's a tough scenario for them.
Mm-hmm. Sometimes family members of patients don't want us to discuss specifics or prognosis with the patient. How do you handle that?
If a family member tells me that for whatever reasons they don't want me to discuss the diagnosis or the outcome with a patient, I feel I'm honor-bound to decline for multiple reasons, not the least of which is medico-legal. The patient needs to know what the situation is. That being said, you don't have to shove it down their throats. You can paint it in many ways. You can paint a picture in many different fashions. And sometimes the only thing that we can do is give people hope. We have no idea whether some of our interesting clinical trials are going to work, and sometimes all we can offer is the opportunity to go on a trial and offer to give them hope. But to hide the truth to someone, I think, is totally unacceptable. I couldn't do it, and I wouldn't expect any physician to do it. And once again, the problem is if someone wants you to hide it from the patient, there's always that potential conflict of interest. What if they're doing it because of financial gain?
Mm-hmm.
And you never know. But to be able to have the patient make an informed decision, I think they need all the facts that they can muster about their diagnosis and their condition.
You mentioned something about hope, and I struggle with this myself as a young oncologist. How do you remain truthful yet give the patient hope at the same time? How do you balance those two?
Well, it helps to be in an investigational institution where you have good protocols, where your patients do better than most, where the patients generally do well. You can honestly tell them that our patients do phenomenally well.
Mm-hmm.
We have ipilimumab, we have PD-1 antibody, we have BRAF MEK drugs, we have vemurafenib, we have TIL. These are fantastic things. I mean, this is absolutely the cutting edge. So it's a pleasure to be at a place like Moffitt where you can look them in the eye and say, we have some good stuff for you.
Mm-hmm.
And you give them the data. I mean, if you give them data where, 35% of your patients are alive without progression at 12 months after starting therapy, that's pretty good.
I see. What if the patient is not at a cancer center like this? Would you please discuss what a clinical trial is for them?
Well, a clinical trial is a test. usually in the community, they're phase 3 trials, which is a trial of sort of the best standard therapy versus an alternative. One would hope it's not going to be a placebo-controlled trial. I certainly couldn't put someone on a placebo-controlled trial if they had stage 4 melanoma. Resected stage 3 disease, we have had placebo trials in scenarios where there's no established therapy, or resected stage 4 disease. But generally, you can't put a metastatic patient on a placebo-controlled trial. And a trial is an investigation. It's a study into whether, in general, if it's a phase 3 trial, treatment A is better than or worse than treatment B. And you'll find out. And it's a controlled environment where I always tell the patients it's a transaction. And I'll say a transaction is where you give something and you get something in return. In a clinical trial, the transaction is you give of your time and of your body, theoretically, although it's not, you don't really give your body, but you give of your time. And it's pretty inconvenient, and there are some risks that you take on that may be a little more than what you would take on with standard treatment. And in return, you get cutting-edge care, a shot at a treatment that may well be better than the standard, and you have the feeling that you're doing something that at some point may help others, even if it doesn't help you. And it may help you. And I think the figure for the U.S. is only about 2% of all melanoma, or cancer patients rather, go on clinical trials. With melanoma, it's probably higher, but in general, most cancer patients don't ever go on trials.
When do you think it's appropriate for a patient to actually enter hospice with metastatic melanoma?
I think the patients will know it, and they'll tell you that they're ready. I mean, it's the physician's job to facilitate them getting to where they need to be. When someone's got a performance status of 2 to 3, if they're no longer able to be even eligible or consider a trial, usually it's time to start thinking about hospice. And even the most unrealistic patients will come around if you present it calmly and reasonably with the facts at your back. No question.
Thank you so much. This has been very educational for me. Thank you for watching. I hope that you've enjoyed it as much as I have. Thank you.